Welcome to the Ortho Joe podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Well, good morning, Marc. I'm excited about today's guest, but just checking in before we get jumping into the details of evidence. How are things going?
Going great. Two things. Just as you can see, I haven't completely given in to the lack of formality, a topic we've discussed many times before, and the issue of professionalism and physician dress. So I always enjoy an opportunity to put on the JBJS tie. And secondly, I do have my priceless
full branding today. I love it.
Ortho Joe mug. And I believe that our guest probably has a whole collection of these by now.
That's a mantle, I'm sure.
Having visited with us several times before. So I'm looking forward to discussing things with this renowned guest.
Well, why don't I go ahead and introduce Professor Jason Busse, who works as a professor in the Department of Anesthesia at McMaster University and also holds a Canada Research Chair, among many other accolades. But Jason, we're here today to chat about a paper that's come out. I suspect it's gotten quite a bit of media. It's a paper that came out recently this past month in British Medical Journal. The title of the paper was Common Interventional Procedures for Chronic Non-Cancer Spine Pain, a systematic review and network meta-analysis, as well as there was a rapid recommendation also published in the same issue of the British Medical Journal. If I could just briefly highlight to our listeners here, this was basically chronic non-cancer spine pain, both chronic axial spine pain and chronic radicular spine pain. About 132 eligible studies, 81 trials ultimately included just under 8,000 patients that explored 13 interventional procedures or combination of procedures. I'll let Dr. Busse kind of speak a little bit about what they found, but maybe not too surprising to some of you, but maybe surprising to others that the results suggest that the majority, in fact, all of the ones they tested didn't seem to have a particularly important clinical benefit for patients. But I'll let Dr. Busse fill us in on this and tell us a little bit about how the reception of this paper has gone.
Yeah, certainly. So great to be with both of you today on Ortho Joe. And your summary of our work is exactly correct. So we were interested to try to understand what the benefit was of these procedures for people that live with chronic non-cancer spine pain. And we were particularly interested to compare their effectiveness against compelling sham procedures. We know from a lot of work that's been done that invasive procedures carry with them substantial non-specific effects. And we've published observational studies on interventional procedures, and they show fairly substantial benefits. But this is why we do randomized controlled trials with compelling sham to understand how much of that benefit is specific to the intervention. And we did find, and we were a little surprised by it, that when we compared the effectiveness against compelling sham in blinded trials, we saw little to no difference in terms of pain relief. And this is an area where there's been a great deal of uncertainty. If you look at the clinical practice guidelines, for every one that comes out that recommends in favor of procedures, there seems to be another one that comes out that recommends against the procedures. For every review that comes out that finds positive findings, another one comes out to show the opposite. So we were very interested to try to disentangle some of this controversy.
And if I can just, I'm going to jump in one more second, Marc, and just give you, and I'll just list the numbers and I'll let you maybe follow up with that. But in the infographic, and just to be clear, it writes strong recommendations against, in the BMJ, a rapid recommendation against epidural injection of a local anesthetic, steroids, or their combination. This is for chronic axial spine pain. Joint radiofrequency ablation with or without joint targeted injection of a local anesthetic or steroids. Joint targeted injection of local anesthetic, steroids, or other combinations, or an intramuscular injection of local anesthetic with or without steroids. So all that doesn't seem to work. Even for the chronic radicular spine pain, dorsal root ganglion radiofrequency with or without epidural injection of local anesthetic or local anesthetic and steroids, and finally epidural injection of local anesthetic, steroids, or their combination. Basically, all of the injectable stuff doesn't seem to be working from the evidence.
Beyond this, what seemed to be a fairly substantial non-specific effect. And again, something like a nerve block is incredibly effective for acute pain. I mean, anyone that's undergone a dental procedure can attest to that. So there was a compelling rationale to think, well, they work so well for acute pain, might they also work well for chronic pain? But unfortunately, the evidence that our study found was they did not seem to have a large specific effect beyond a compelling sham.
Well, thanks for that summary, both of you. I'm sure we have some younger early career investigators, and I was just wondering, Jason, if you could go over the difference between a network meta-analysis and a standard meta-analysis.
Yeah, it's a great question. So a network meta-analysis allows us to enrich the data that's available. So we have the direct evidence, which you get through conventional meta-analysis, and we have to do that. So that is a precondition of doing a network. All of the conventional pairwise meta-analyses has to be done. But then by virtue of a common comparator, and in this case, it was largely sham, we can then create indirect evidence. So we can compare a joint radiofrequency ablation against an epidural steroid injection, even if we don't have a lot of primary data that has compared those two procedures. So it gives us additional information and it allows us to increase the precision around the treatment effects. So it is a bit more of a complex process, but it gives us more information to work with.
Jason, in the hierarchy of evidence for a treatment, where does a network meta-analysis sit?
So a network meta-analysis, again, it can allow us to increase the precision around the estimates and compare active interventions against one another. So a patient has to come in and be suitable for consideration of the different treatments that are being considered. And of course, there are some interventional procedures that you would not use for axial pain, but you would use for referred pain. So we do have to have separate networks for those two types of presentations. But a well-done network meta-analysis is increasingly being relied upon to inform the evidence when you have competing interventions for a common indication. So it should be seen at the same level as a conventional meta-analysis, where it provides us with the best estimate of the current evidence out there, but it does use this ability to create indirect evidence to give us additional information than we would otherwise have.
Can you just maybe explain a little bit about the sham procedure? So, for example, there have been network meta-analysis where you can actually get some insight into the effect of doing a control, like, the control itself, whether it's a saline injection or a sham procedure. Were you able to identify whether or not just having a sham injection itself, or a placebo injection itself, had an effect on its own? Network can sometimes give you those insights.
Yeah, I'd have to go back to look at some of the specific details in our supplementary file, but we do have some ability to explore the effect of a sham versus usual care, for example. And we did see some evidence that just receiving a sham did provide noticeable significant benefit to patients. There was a fascinating randomized trial recently published in JAMA Psychiatry, where they actually randomized patients with chronic back pain to 3 different treatment arms. One was usual care, one was the intervention they were very interested in, and the other one was an open label placebo. They told patients, we are going to inject the part of your back that hurts with a subdermal saline injection. That's it. It has no specific mechanism of action, but they made them watch a video about the power of nonspecific effects, the power of the placebo. And at 1-year follow-up, 20% of those patients reported either complete pain relief or a 1 out of 10 pain. So receiving placebo, even when it is open label, even when you tell patients, seems to have potentially large benefits. And there's been a group out of Harvard led by Ted Kapchuk and others that has actually been using the evidence accumulating in this space to argue for the ethical use of open label placebos in clinical practice. Obviously remains a very controversial topic. It is not widely used, but they're continuing to show that in conditions such as chronic pain, the act of doing something, in a particular something invasive, can have substantial benefits in and of itself.
That's fascinating. Let's cut to the chase, because I'm sure every member of the listening audience or viewing audience has got the same issue. A relative or a friend's relative, let's just say 64-year-old female, not morbidly obese, has chronic back pain of 6 years, has tried physical therapy, and is asking you at a cocktail party or at the place where you worship or at the health club, what should I do for my chronic pain? What's the answer based on your work?
Well, the work we did just focused on interventional procedures would unfortunately suggest to us that the current best evidence would not support that they are going to have specific benefit. They may indeed, and they well have non-specific benefit, but does that warrant their use, given the invasive nature, the possibility of complications? Some of the complications are quite rare, and the cost of the procedure. Now, I should caution at the same time that some of the evidence we had was only lower, very low certainty. And so we have concluded that additional research is perfectly reasonable. To administer these procedures in the context of a clinical trial would be a great next step for people that feel convinced that they can demonstrate effectiveness in certain patient populations. But to your point about the recommendation that arises from our work, it would be, at this point, unfortunately, we do not see evidence of that specific benefit in order to justify providing them in practice.
Well, I'm sure you have extensive knowledge of the field, though. What are the current recommendations that are not perhaps direct intervention based?
Yeah, it's a great question. And I should just state in terms of full disclosure, we are working with a group right now looking at developing guidance for management of chronic low back pain in primary care practice across all interventions that have been considered. So there's a very, very large 300 study network meta-analysis that we've been working away on now for a couple of years. So I will know better later this year what the sort of compelling answer to that question might be. The reality seems to be that there are a large number of interventions for people with chronic back pain that work a little for some people. There are some that have shown large signals, but the evidence needs to be replicated. So just to give an example, in the trial I mentioned in JAMA Psychiatry, the third arm, so they had usual care, they had the open label sham procedure. The third arm was something called pain reprocessing therapy, where really it's a form of sort of reconceptualizing how you react and respond to the experience of pain. And they demonstrated about a 60% resolution of complaints at 1 year. This was a well-done trial. They're currently working on replicating the results, but it would suggest the potential for interventions that work more on central processing in some cases. And there's been a recent pilot study I saw in the journal Pain, sort of a similar approach. Again, it was a smaller study, but the same sort of effect seen. So it's difficult to come up with a one-size-fits-all approach for chronic pain. People are different, their concerns are different, the way they got there is different. So it is going to be a matter of working with that individual. But, we know from a recent Cochrane review that, getting people involved in more physical activation can often be a helpful thing. Some of these central approaches can be helpful. There may be cases in which people will respond to direct interventions to reduce their pain to some degree. Some evidence exists out there for, several interventions. Some people get some benefit. But again, it tends to be working with the individual and trying different things and seeing what might work for them.
Jason, I imagine as we close this out, you've had lots of interest in this paper. I imagine there's lots of individuals who have paid particular attention to this study. And I'm wondering what the reception's been for you with respect to either letters coming back in, issues. I imagine not everyone's happy with these findings, but I'm curious what the reception's been.
Yeah, the reception has been mixed. So some groups have acknowledged that the results were not surprising, that it builds on efforts that they're aware of. Other groups have been disappointed by the results and felt that it is a very much contraindicated by their experience in clinical practice, which I'm entirely sympathetic to. We know that, again, observational data supports large effects of these procedures, and we've published work on that. So I'm very, very sympathetic to that perspective. Our goal is to be entirely transparent. So all of our data is freely available. We have already provided it to 2 separate groups that have asked. They're going to undertake reanalysis. We encourage this. Our goal is to be fully transparent. This is the information we have. This is how we appraised it. These were the results. So I welcome the opportunity when the comments come in to make clarifications. If you're going to publish work in controversial areas, I think you have to be transparent and you have to be willing to take criticism. So we're very open to that. And if we can identify strategies to improve the work that we do, we're always very open to that as well.
I mean, that's an extremely, like I said, transparent way to approach things, where you're really letting the community know that our data is completely open, and more importantly, feel free to reanalyze the work. Doesn't always happen, Jason. So I think kudos to you and the group and the large group of investigators who have done this work. Just briefly, as we close out, maybe my last question to you, on behalf of myself and Marc, is what's next for you? It sounds like you're doing the big one. So you kind of alluded to this very large network meta-analysis. Is that the next big project in chronic pain that you're working towards? And when might we see that paper someday published?
Yeah. So, and I will say that network meta-analysis is being led by a group out of Australia. So we are providing some assistance, but we're not leading that. But we are partnering with them to complement their work with a guideline based on the findings. I would anticipate that work will be completed this year, but it has been a large undertaking. They've been working away on that, as you might imagine, for a couple of years now, and trying to be very careful in terms of categorizing the types of interventions and the types of back pain that are coming in. People are always very curious about subgroups. They say, well, maybe the overall aggregate effect was not significant, but what about this particular type of patient with a certain type of complaint or certain other features? So we're interested to look at these things. We're trying to engage with clinical experts to really understand where the areas of controversy might lie and if we can address those. So we'll do our best. And as I said, I'm quite confident that we'll have the project wrapped up this year. In terms of when it's published, as you both well know, there is sometimes a bit of a lag between completion of work and publication.
Absolutely. Thank you so much. On behalf of myself and Marc, thank you so much for taking time. You always bring a considerable degree of insight and wisdom to your work. And I do hope you stay out of the front pages of newspapers on this one, because I know this is a pretty important topic and there's a lot of controversy. And I know you're no fan of being on the front page for controversial results. So have yourself a great weekend, Jason. Thank you so much for joining us on Ortho Joe.
Yeah, thanks so much to both of you. Have a great day.
All right, take care.